So what I was going to call this talk, and the tentative title is going to be some ribcage bullshit. All right, because that's what we're going to talk about today. And the reason why we're going to talk about the ribcage today is one thing, and this is one of two things that drives me and drives the decisions I make and the things I learn. Outcome. What's your result? How can you impact someone's life in the most effective way possible to meet their goals? Now, there's certain outcome measures that I look at when I'm looking at someone, but no one really gives a shit if we improve shoulder internal rotation. Get it? Like, Pat, you do something on the table, you see a substantial change, all the bros are like, oh, damn, fam, that looks great. Your client's still like, bro, I want to get jacked. I don't give a shit about that. So it's not about what you want, it's about what they want. And so what I have to search for is how can I maximize their results with the minimal amount of work possible, minimal effective dose. And when I was in PT school, the outcomes were pretty much body part specific. So if someone has lateral epicondylitis, we're going to do particular diagnostic interventions to say, okay, yep, it hurts when I do this, hurts when I stretch, probably lateral epicondylitis. We're going to do these things to treat that specific area, alleviate pain. Well, the problem is when you get to the clinic, the person you're treating has lateral epicondylitis, but they also have knee pain, they're also anxious, and their wife just left them. Like, that's a complex problem that requires multiple holistic and systemic solutions. And so it requires upon us to dive into a lot of areas to get this for our people. Think about all the things that you guys have learned over the last week. How many of us are going to have the physiology and training knowledge that Pat has, the neurology knowledge that Mike T has, the hypertrophy knowledge that Ryan has, the functional medicine knowledge that Ben has? I go on. How many of us can get that? But Eric, well, let's not even use him as an example. How many of us need all the shit that he talked about too, right? But our clients need that. That's a big problem for us to have. And me personally, guys, I'm kind of stupid. Like, I'm never going to know that stuff as well as Pat does or as Eric does. So the other key that's going to drive this for me is simple, or simplicity. How can I make what I do as simple for me to understand as possible? And that's part of the reason why I do all these course notes and review all this stuff, is because it helps me understand how I can help my clients reach their goals. But more importantly, I can only help so many people. Because I only work with people one-on-one for 45 minutes, in person, one-on-one for an hour, offline or online. But you know what? If I can teach you guys how to do things better in the simplest way possible, to maybe where you don't understand this thing to the extent that I do, but you can still get your client results, well then, I've helped more people. We've all win. Because guys, it's this simple. Like, look at this goddamn thing. How many joints are here? How many bones? How many different tattoos this guy got? Like, this stuff's not easy. And the stuff that I'm going to talk to you guys about today came from trying to make this, which we all work with, easier to work with and simpler. And that's why from PT school, going from just trying to figure out lateral epicondylitis, I have to look at work or impacting all of this, because if I have someone who hurts multiple areas, or if I'm a trainer and I'm excellent at coaching the squat, but for some reason they still can't achieve depth, I need to know how to impact this thing systemically to help reach one of those goals, or whatever the client's goal is. And so that kind of led me down the FMS, SFMA path, that led me down the PRI path, that led me down to taking way more Con Ed courses than I probably should have. And they're all right to an extent, but they're also all wrong to an extent. Because the problem that I kept running into was the big driving force for our movement capabilities has to do with this, the spine. Because this thing really is just one piece. If I increase lordosis at the cervical spine, which is normal, I have to get a corresponding increase in lordosis at the lumbar spine. If I increase kyphosis in the thoracic spine, I get an increased kyphosis at the sacrum. And the way we were trying to measure this was through these things, scapula, and these things, shoulders. And then when we get downstairs to, the good spots and stuff, these things. Well, the problem, guys, is I'm trying to use proxy measures here and here to try to do things here. But these guys, have their own problems. What if I have a labral tear? Is that going to be an accurate way to measure what's going on here? No, because there's laxity now at the shoulder. What if I have someone who has congenital hip dysplasia on that right hip? Can we use that as an accurate measure to tell us what's going on here? No. Or how about this? What if I have someone who does something wild and crazy at their lumbar spine? Maybe they have a spondylolisthesis, and that alters the mechanics of this one thing. What's that going to do to my proxy measures down there? It's really tough. So what I've tried to do with some of the measures, and this is nothing that I made, like when we're going to talk about infrasternal angle, this is straight up Shirley Starman, guys. So like this stuff ain't new. It's been around for a hot minute. But the reason why I'm going more towards this and trying to find ways to measure this is because there's fewer ways we can compensate there. There's so many more degrees of freedom at the glenohumeral joint than there is here. And so if we can find ways to at least accurately measure this, then we can be more accurate at providing a minimal effective dose for our clients to reach their movement goals, have them do less work, and get us on to more important shit. Whether that's hypertrophy, whether that's fat loss, whether that's reducing anxiety, whatever. I want to get through this as quickly as humanly possible so we can get to the more important stuff. And so the best way that I can impact this is through respiration, in my opinion. And the reason why is because when we breathe in and breathe out, this whole thing has to move. I want you guys to stop breaking this down into thorax, abdominal region, and pelvic region. And let's just call it one thing, thoraco-abdominal pelvic cavity. Because this thing moves as one piece every time we take a breath of air in and a breath of air out. So the first thing we have to understand is, what does normal look like? Thing we won't see. So the way this thing works is as the diaphragm descends, there's certain things that have to happen certain things that happen at the rib cage in order to maximize gas exchange, because that's really what breathing is about, maximizing gas exchange. So as this descends, what happens? I'll try to draw this out, but I'm going to apologize in advance. I suck at drawing. From a global perspective, if this is the thoraco-abdominal pelvic cavity, when I breathe in, this gets bigger. I get an increase in pressure in all directions, so the lungs can maximally fill, the tissues can get the gases that they need, life's good. And as I blow out, ideally this gets back to this size, so then we can exchange and get fresh air. Breaking it down to what this is, under normal circumstances, as the diaphragm descends. Yeah, I got to struggle with this. Let's do a side view. So let's see, we got cervical spine, thoracic spine, lumbar spine, sacrum. Okay? And we got sternum right here. As the diaphragm descends, these guys right here are going to spread apart. So I get the bucket handle action at the rib cage. Most prominent in the lower portion, but there is a bucket handle effect at the upper portion of the rib cage. So this is going to expand out. That's the side view. Diaphragm descends. What also happens laterally is I get the crap in here, the guts also pushing out. This is how we develop intra-abdominal pressure. Because to maximize gas exchange, I have to have the pressure down here equal to the pressure up here. So we get this dropping, lateral rib cage goes out, guts go out to the side, life is good. From the side view. And this is where this is going to come in. Ideally, I want the pump handle action of the sternum to come up this way. So it's an anterior and superior rise of the sternum. This also creates the pump handle action of the ribs to go forward and up. So what happens is air, which will be blue, is going to go this way. Okay? Diaphragm descends, so we're going to get air filling that way. What else happens is the posterior thorax, right here, has to expand out. So I can feel the posterior aspect of the lungs. So I get airflow also going this way. All right. Y'all doing okay so far? What else has to happen, guys? Well, I'm getting good pressure here, here, and here, but also this first rib has to come up. We talk about first rib elevation, first rib depression, getting too much scalenes or SCM. Scalenes are a primary muscle of inspiration. Like, this is not a bad thing. It's when this guy goes rampant that we run into problems. So this has to come up so I get pressure increasing up here. All right? That's normal, and that's the thorax. If we move downstairs to the abdomen, well, we already said, guys, we should get some lateral expansion of the guts into the abdomen. But we also want anterior and posterior displacement of the guts to maximize pressure there. So here we're also getting a relative kyphosis of the thorax and lumbar spine because everything is pushing back, getting guts going this way. And then last but not least, what's the first rib of down here? Pelvic floor. This has to descend so I can get the goods pressing down there to maintain pressure. It is this mechanism that allows me to get effective gas exchange. Questions so far? And are we all kind of sort of on the same page? All right, this is normal. Now remember, guys, this to this, the whole spine kind of goes into a relative kyphosis because that helps create that back circle. If I get a relative kyphosis or counternutation of the sacrum, then the hemipelvi have to dip forward. Flexion, abduction, and external rotation. Okay? So this, and I can't move this, but this has to come forward so the sacrum has to come back. Yes, sir?
This is all still inhalation, correct?
This is inhalation, yep. And this is normal mechanics. Yep. And so another measure that we kind of look at, we can't measure this directly unless you want to get sued. This angle right here, the infrapubic angle, as I breathe in, yeah, except Pat. People pay Pat good money for that. Oh, I will. And abuse. So as this goes forward, this angle has to close. Because as this closes, that allows the pelvic floor to descend. The goods get pushed down there, and we maintain good pressure in the pelvic region. All right? So an interesting relationship. Under normal conditions, this angle closes. This angle, remember, because there's bucket handle action of the rib cage, opens. So they are opposites. Yes. So as I take a breath of air in, under normal conditions, the infrapubic angle, which is, you can't see it, but basically this angle here closes. That allows the pelvic floor to descend to take the genitals, among other things.
Is that angle like our butthole?
Is that your butthole?
Yeah, the angle you're talking about.
It'd be right here. Like, so mons pubis, you know, the bony part when, you know, you're having fun. So that's the front portion of it. If you dive lower to that, really hard to palpate, that would be that angle. Butthole would be other side of that.
What are the two points of the angle?
Hang on, Mike first. Go ahead.
What's happening from a pelvic inlet and outlet perspective when that happens? When the pubic angle closes?
Outlet closes, inlet opens. Yep. So the angle would be pubic symphysis is your top point, and then the pubic rami, the inferior pubic rami would be the bottom portion of the angle.
Posterior.
Yes. Yes. Okay.
Correct.
How are we doing so far, team? All getting this? Cool. And then the infrasternal angle, that's the lateral expansion of the rib cage. And this is important because I think a lot of people who I work with, and even myself included, have messed this up. What that angle is is, so we got our sternum right here, right? You guys can feel this on yourself. Yeah. Sternum's hard. We want to use the xiphoid process as our pubic symphysis. Like this is the same thing. I measure from here, and then it's the angle of these false ribs here that I'm measuring. So it's this. If you're doing this, you're not getting an accurate measure because everyone's going to seem wide and you're like, man, I haven't seen a narrow person in a day. I guarantee you, I don't think any of us are narrow here because you have to measure from where that angle actually occurs.
Why is there
Narrow. Everyone, I would bet money that everyone is narrow here. All right?
Yeah, I have just a question. I mean, because I would assume everyone here is going to have that PVC pelvis. You know what I mean? And wouldn't that be associated with a wide angle?
We'll get to it. Yeah, yes. Kind of. And the reason why we're looking at this is because this area of the spine and the rib cage has a little bit more compensatory activity than, say, up here. Because this T1 to T7, because we share a common attachment at the sternum, moves as a cohesive unit. So it's hard for these ribs to move independently. This area has a much better chance of moving independently. All right? How are we doing so far? Does everyone kind of understand what happens when I take a breath in under normal circumstances? Now, how many of us work with normal people? Yeah.
What's normal?
general?
Yeah. People who you think have this, because and what I would say is if you can do this, you probably move pretty well at all joints. You have about a 90-degree external angle, which is what we're using as a norm. I would assume probably no one. So we have to look at what happens for whatever reason, alterations in pressure, I don't know. It's something that we do to manage existence. What happens when this respiratory mechanism goes awry? The reason why I like this is because there's fewer compensatory strategies we have at our disposal to make this happen. So, as the diaphragm descends, guys, what happens to the lateral ribs? They go out. Okay? Well, let's say that I descend the diaphragm, and for whatever reason, and the set point of the diaphragm, I believe, can change within 4 to 6 weeks, so use that as your litmus test. I'd have to get the reference on it. But as the diaphragm descends, what if I never get the chance to fully ascend? This right here is going to appear much wider than norm, right? And we're using norm for the infrasternal angle as 90 degrees. That's just what they've come up with in terms of Shirley. I don't have a best guess, but I can tell you that it'll probably make a little bit more sense as I dive into this, why we're using that as our number, okay? So as the diaphragm descends, the infrasternal angle is going to be wide. And what that means is that these angles are going to be much greater than 45 degrees on both sides. So much greater than 90. I use like 100, 110 probably as a number, okay? Now what this is going to do is it's going to change the mechanics that happen at the spine and what happened up here. Let's look spine first. In the spine, as the diaphragm descends, what happens is those nice curves that we had, so we have cervical lordosis, thoracic kyphosis, lumbar lordosis, sacral counternutation, or sacral kyphosis, I should say. All of these curves become exaggerated. Because what happens is, because of some alteration in pressure, instead of this and this being opposite as I breathe in, these two things now match. So my infrasternal angle is now the same as my infrapubic angle. So if this is wider than norm, this has to be wider than norm. All right? So if I have a wider infrapubic angle, that's posterior rotation of the innominate. What that's going to create is a relative nutation at the sacrum. So instead of I'm breathing in and this is happening, I'm breathing in and this is happening. Okay? Now remember, guys, the spinal curves, assuming that there is no crazy hinging or crazy mechanics, these guys move as one piece. So if I have an increase in nutation of the sacrum, I have to have an increase in lordosis. I have to have an increase in kyphosis, and I have to have an increase in lordosis. Right? They all move as one piece. So if you're wide, the curves exaggerate. That's going to do some funky things to the rib cage. Now, when I take a breath of air in, what happens to the posterior thorax? It should expand. So, well, what happens if I have an increase in kyphosis? Do you think it's already expanded, right? So I do really well if I'm wide getting air back here. Okay? If I do well getting air back here, scaps have to come a little bit more forward. Right? That's normal. This is a normal compensatory strategy that we have. If I do super good at getting air back here, to manage pressure, effectively what's going to happen is I'm actually going to lose my capability of expanding air in the front. I've overdone this, so I can't do this. So what happens is this guy is now a down pump handle. All right? Now what makes this kind of complicated is you can't just look at someone and say, oh yeah, clearly a down pump handle, because sometimes you'll see people with a wide infrasternal angle that looks like that you can clearly see the sternum. I'm sure you all have seen this if you're looking at this stuff. Well, watch this, guys. I got a pump handle down right now, right? Because I took a nice exhale. How am I looking now?
Sexy.
Right? Yeah, right? So here, it looks like the pump handle's up, but in reality, due to respiratory position, it's not. There was something that I did at the spine to compensate with that. How are we doing so far with this? Okay, this is just from a wide. Now, to your point, Pat, because you mentioned that if I have someone who's a PEC patient, if we're talking about PRI, where we're taught that the pelvis is tipped forward, in this case, because the sacrum is nutated, the pelvis ought to be posteriorly rotated, right? Well, what happens if I keep driving sacral nutation? Or I keep exaggerating this curve? What do you think happens? Because how many degrees of freedom are there within the SI joint? Not much. So what can happen is I might have this be my relative motion that happens, but if I continue to increase lordosis, it looks like the pelvis is facing forward. Can you see that? Another reason why this is hard to trust. Yes?
So you have a posteriorly rotated pelvis locally orthotic or extended lumbar spine.
Or just an exaggerated curvature of the spine. Yeah.
Okay.
Which again is why I continue to come back to this, because based on normal mechanics, if I'm posteriorly rotated at the hips, I should be able to clear hip adduction because the femur does not get dinged on the superior aspect of the acetabulum. Because if this comes forward, if this is forward and I go to do this, well, I hit on the top portion. So if I can rotate this back, see if I can do this again. If this comes forward and I try to adduct the femur, I hit the top portion, I can't do it. Also, if you look at the study and anatomic investigation of the Overs test, if things tighten up back here, which happens with an anterior rotation of the innominate, I can't get full excursion of that hip adduction movement. So if I'm posteriorly rotated, that should allow the femur to clear this upper portion of the acetabulum and I can adduct. We're doing okay with that? But what would happen is the flip side where I wouldn't be able to abduct because as this opens, right here, the thing that opens up the infrapubic angle is your abductors because they attach on the outside of the pelvis, right? So then if these guys are on, I can't do that. But then things change where if this is wide, and then because of curve exaggeration of the spine, this whole thing comes forward. So I have a case where the infrapubic angle is now wide, but because everything is dipped forward, the positions that these bones are at are changed. Does that make sense?
So I mean, I might need to have a conversation after this. Like, these are always these things that, like,
Yeah.
first time hearing it, it's like, I think I'm picking up the essence,
Yeah.
but maybe not some of the details.
Yeah, and that's the thing though. That's why like I'm still using this stuff, but it gets complicated. I would hope you guys are somewhat confused right now. And that's why I'm still using this as my primary decision making, because there's no confusion here. It's like there's no way that I can have someone who's wide appear narrow. Like due to the constraints within here, it's just not possible.
Could you review super quick to make sure I'm on the same page of, from looking at that angle, what's normal and what you're trying to see at the end of the session, just so I have an idea of where we start and where we end?
So ideally, I'm shooting for 90 degrees
Okay.
symmetrical. That's what the model is beginning, and the reason why we're thinking that is because that's the typical angle of maximal diaphragm being ascending. That's what I would say. And it'll make more sense when you see the converse of like someone who is much less than that. Why we can't do that? Because the diaphragm can only ascend so far. Right? Yes?
I know we talked about 100 to 110 degrees for wide. What would you consider an aisle?
Good question. I will get to that. How are we doing on the concept of a wide infrasternal angle? I'll summarize this if I can. Basically what happens, this widens, this angle right here gets wider. I get really good at filling back here. I suck at filling here. This is opened up, so the pelvis is relatively posteriorly rotated. All of this is connected because these curves of the spine, because remember they move as one piece, are exaggerated. All right, so cervical lordosis is increased, lumbar lordosis is increased, thoracic kyphosis and sacrokyphosis are all increased. Questions about that so far? Yes.
Would that kind of present as like this way back position?
That would actually be the narrow.
The narrow.
This would be someone who, overweight client, big hard belly, because they're really good at getting pressure to go down here. Or you guys have seen this chick, apple shape, walks like this, really skinny legs. Yes.
So you have the exaggerated curve. You said it's relative posterior tilt.
Rotation, not tilt.
Okay.
Tilt would equate tilt and orientation is the same thing.
Okay.
So it
you
still
got
is tilted.
posterior.
Well, tilt would be what direction is this thing facing? Rotation is the flexion, abduction, external rotation, and extension, abduction, internal rotation. It's just different mechanics. Because what I can do is I can tilt or I can rotate the pelvis posteriorly into extension, abduction, internal rotation, and then I can tilt the whole thing forward by exaggerating curves more.
So tilt is orientation.
I would say those two are synonymous. Rotation deals with the relative action at the SI joint.
Okay. So you got a posterior rotation.
Yes.
Now because of that, you should be able to get a negative oversize because it is rear rim. But because of what does it do, that doesn't clear the overtest?
If I exaggerate this curve here,
Yeah.
or the curves, what happens is the sacrum now faces more and more and more forward. There's very little motion at the SI joint, so the pelvis has to come with it.
So then you're getting an anterior orientation because of that.
Yes, 100%. But the angle of the infracubic is still the same. It's just the whole thing is tipped forward.
Can you think of that as like just anterior translation? Is that different? Like the whole, everything's just coming forward. It's not that. It's not that it's just literally coming forward, but there is still a rotation component to it.
Yes, but the rotation is backwards.
Rotation backwards.
It would be like,
I guess if you just follow the curves,
yeah,
that makes sense,
it's
right?
this,
Yeah, okay.
as opposed to
I guess I was just always thinking of that wide infrasternal angle being associated with the anterior tilt.
it can be, but not always.
Not always. Okay, well that's what I was.
But more often than not, it is. Because most people have to exaggerate, have to extend to do all of the things they need to do to manage gravity. Pat and then Henry.
Is it fair to say here that we're good at expanding things backwards due to the inhalation orientation we simply are taking some kind of force that's driving this cavity forward, just lumped on top of that.
Yeah, I'm 100% fair with that. Henry?
So yeah, you just demo posterior rotation again with each anomaly, because I can't get something like that right now.
So, what that would be, think SI joint, or think the sacrum. This is my anomaly. If this goes forward, I just move this forward, I nutate. This is posteriorly rotated, because I just moved here, right? And the combined action of posterior rotation is extension, adduction, internal rotation of the inlet,
Okay.
right? Flip-flop that. Here, this is more forward. Flexion, abduction, external rotation of the inlet, okay? That is different than me getting exaggeration at the rest of the spine, changing the orientation of the whole dang thing. Because that's relative motion is still present. It's just, there's very little motion at the SI joint itself to be able to overcome that.
Because they can't get air into the anterior thorax, you say these people are not hyper-inflated, it just appears to be because of their extension.
Has to deal with location of hyperinflation. They're most certainly hyperinflated posteriorly,
Yeah.
but they can't get enough air
It
anteriorly.
just appears that way because of their presentation.
Yes. Okay.
The most extreme end of this would be like COPD.
That I would argue is the next case, which would be your narrow. Yep. Anyone else? We're doing okay? And I'll go over what this looks like from an intervention standpoint to change, but yes.
So you're saying this is a continuum, so this would, did they go through this to get to that?
Yes, this would be like your phase one. All right? But this is wide, yeah. Yeah, and I'll show you all narrow. James.
So I guess like, thinking back when I was first getting into MRI land, so this is the person we see who we put on a table, like either in like belly lift or whatever you call it, like they don't have the ability to expand posteriorly because they are already like at capacity of being able to, if that makes sense what I'm saying? It's like they've already inflated posteriorly, so I can't see any more expansion posteriorly.
You could argue that, but where this gets confusing, and that's again why I'm going to come back to this, is because normally the scap should protract in this scenario. Well, what happens if there's some compensatory action at the scapula itself that creates an IR scap? Because you'll see these people have limitations in internal or external rotation sometimes. So like it becomes complex, and that might make you get like a pseudo I can posteriorly expand, which again is why like these guys, even though I use them liberally, like it complicates things because I don't know until I've done everything I can possible to minimize the axial skeleton as the rate limiting step in my decision making. We're good with wides, at least as best as we can. Sweet. Narrow. Now you would think that the narrow would be, well, this is probably someone who's just way ascended. But I can only go so far this way. But there's an interesting mechanical thing that happens as I continue to descend that diaphragm. If I go to flat and I fill up the lungs maximally, the mechanics of this invert, right? So what happens instead, this would be a wide, and narrow. What happens instead is if the mechanics invert, these portions of the lower ribs come closer together. Right? So if I keep tilting this, then this portion kind of goes farther apart. I get a narrowing of the side-to-side dimensions of the rib cage. And it has to be more so than I got when I'm at rest with my 90 degrees. So the way that this happens is pretty interesting, as Bill would say. As this descends, a way I can make this narrower is, you see how there's like a little bit of a bend in the ribs? I can straighten these things for external rotation. Not necessarily this kind of ER-IR, which we probably all learned, but think of rotation as this, ER-IR. I can straighten or externally rotate the ribs via a big muscle right here. What muscle do you think that would be? On the outside of the ribs that kind of runs this way. External obliques, 100. That's going to pull this way. And another action of the external oblique is to compress the rib cage. So because the diaphragm descends, this inverts a little more. The EOs can get a little bit of leverage, compress this thing further, pull it forward. All right? That's laterally. If we go to our spine model, pretty simple, guys. It's the reverse of this. So if the wide curves narrow, well, if I get inverted mechanics, what do you think is going to happen to all the spinal curves? All right. In the wide case, if I could expand posteriorly, what do you think I can do on this side? Where do you think I'm going to expand better at? Anteriorly, yep, 100%. So this is up. That's way down. All right. Remember, infrasternal and infrapubic angle now match. So what do you think the infrapubic angle is going to be for this person? It matches under compensatory circumstances. It would be narrow. So now what we have is the innominates are anteriorly rotated. Flexion, abduction, external rotation, because I have a relative kyphosis at the SI joint. All right? This is your sway back. This is me. Right? All day, every day. I'm dipped forward right here, or you get someone who's doing this. All right? Questions on the narrow so far?
The inversion thing is still something I'm struggling with conceptualizing, quite honestly. I kind of hear the words that you're saying in terms of the diaphragm descends, it's flat, and then you take an inhale on top of that, and then I see things involving EOs and straighter ribs, but there's something there where I'm not connecting exactly what you meant by this inversion component.
The inverted mechanics. So I would point you to Detroyer's work because he talks about this. But what happens is as this descends, so if I'm at rest, exhalation, full exhalation, as this descends, if my wrists are the rib cage, you have to have lateral expansion occur. What if this goes too far? That's where I get the inversion.
Okay.
Right?
And that leverages EOs even more.
That gives the EOs leverage. And the EOs, their action at the lower portion of the rib cage is external rotation. So think of, if I'm looking at, this is a good point, I should have brought this up sooner. If I'm looking at a rib cage, superior to inferior view, so I'm looking at this view, right? And we're looking at lower ribs. Right? Follow me so far? If I'm looking at lower ribs, and this is narrow, the way I can narrow this is I have to bring this in closer, right? And I have to make this, the anterior to posterior dimensions, a bit longer, right? So in order for me to do that, I have to bring this in somehow. So if this comes in, I have to do something like this because these ribs are bent. Can you see that? So if I make this straighter, I can get these dimensions to go a little bit better because I can't just take this and then do this. Like that's just not how the ribcage mechanics work because the bucket handle action is a curved action. So this is like more a calipering effect at the ribcage. Right? It is this position that allows the external obliques, due to their attachment at this portion of the rib cage, to gain leverage to compress that in further. Because on the flip side, and I didn't talk about this, if I'm a wide, and we'll use wide as a red, I get simply the reverse. I get an increase in the lateral dimensions of the rib cage. So these get more bendy. Okay? If these get more bendy and the EOs attach here, just due to their attachment site, as this closes in, these guys can't get leverage because they're getting pulled along the lateral aspect or the outside of the rib cage. So if things on the internal side have a better length tension relationship, your IOs and TAs, to contract. Right? Because the muscles on the muscles on the outside have to go around this curve now to function. But then once I get to this scenario, they don't have to go around that big curve. Like their attachment points are much shorter. On the flip side, muscles on the inside have much less distance to travel to contract versus on the in the narrow side of things, this is much longer. Does that make sense? And even if you don't understand the muscles, guys, just think about what has to happen here to make the mechanics work. In the narrow, if this gets smaller, just due to how the ribs work, front to back I have to get longer. If this gets wider, front to back, because remember that the mechanics do not work perfectly in compensatory conditions, front to back I have to get smaller.
So are we going to see people with narrow ribcage angles presenting with less ribcage movement? You trying to accompany the move?
Yeah, possibly. I mean, I can see it. You can see it either way. If you're in a position long enough. Yeah.
When Ben was saying this is a continuum, that's what you guys found, right?
Mm-hmm.
So someone in that scenario has to at first pass through wide, or is that by drawing length?
I would say not necessarily. I sometimes see that, but it's pretty rare. Because really what we're trying to do is get someone closer to that middle ground. And it's just clinically it doesn't happen. Shortcoming of the model.
So then where does the E-burden stuff come in as far as when you were saying the flattening of the diaphragm and the ribs, too much that will lead to a narrow, right?
Yeah, if the diaphragm descends too far, the mechanics of the rib cage invert. And that just has to do with normal mechanics of the rib cage. Right? And what they're doing is they're isolating specific muscles, having them contract, and use that to measure what muscle X does to the ribs.
Yeah. I guess I'm just trying to, like, in my mind, I mean, I'm sure I kind of had that stuff previously, to the point where I'm trying to, like, have a picture in my mind, like, what is, like, a diaphragm that's descended too far?
Completely flat. Maximal inhalation, someone with COPD, where the lungs are hyperinflated.
Okay.
Because if I continue to fill up the lungs, and they keep getting bigger and bigger and bigger, this has to drop.
So if I take a maximal inhale, I guess what is the point at which that starts to become dumb? We're going to use that word. I guess if I just take a maximal inhale now, I just send my diaphragm. Right? Like I'm going to expansion front back side. Maybe I won't, but like theoretically, expansion front back side to side. Then there's kind of like this point at which my diaphragm descends farther than this. Now this narrows and this has to expand.
Yeah.
I guess what I'm asking, like, where is that transition point of like I'm normally sending my diaphragm because I want to use it as an inhale versus the fact that well, fuck, like I went too far.
Yeah.
And now I'm in this position of compensation where like I'm narrow and I'm long.
Yeah.
Am I framing this correctly? Following me at all?
Yes, I get what you're saying. I would have to say that is probably different for each individual because we have a set point of how much air we can actually take in versus take out. Like the amount you can, the amount of cc's you can blow out is going to be different than the amount that I can. So that's probably going to alter our diaphragmatic excursions, especially if we're talking about default positioning. Right? You can't compare yourself to someone's breathing mechanics to someone who has COPD. Like, what is their point of no return? Well, it's a different set point. Just like you're going to put on muscle different than I am, or you're going to be able to, I mean, we're just different creatures in that regard. So we have to understand that this is going to be different per person.
We're still essentially coming back to the scenario where we have someone who is a great inhaler, but they suck at exhaling.
Yes.
And it's still coming back to that kind of like big picture concept.
Yes. And really both of these guys suck at exhaling, but they're going to require a different strategy in order to get close to our normal model. questions? Jack.
So the narrow, the 2 arrows, is that saying air is going down and then it's coming up too?
Sorry, that's poor. There increased air in the front, decreased air in the back. Yeah. Anyone else? Pat, yeah.
This is probably almost a stupid question, but like, you know, you're kind of saying like, people fear that you'd be hypertrophy is going to be narrow. And like, I can't help, like, I got Ryan in like, directly in front of me. And he's like the widest dude I've ever seen. You know what I mean? And it's kind of like, I don't see him as being that, like, he's much wider lateral to lateral as compared to A to B. And it's just like, it's just so hard for me to like, me and my brain be like, this guy is narrow, like, you know what I'm saying?
Mm-hmm. Ryan's also very tall too. So think about gravity, right? He has much more distance to deal with in terms of a gravitational standpoint. So that could potentially push that down even further. Like most tall, slender people, were you a tall, slender guy before you went Gainesville?
I mean, there was never before Gainesville.
Okay.
I don't know if I started
Same.
Fair enough.
So I have no idea.
Gotcha.
But I would say my brothers, yeah, they're taller and they're
Yeah.
lanky.
Yeah.
Well, I'm certainly not tall and slender, never have been. And like, you know, you're just saying like, guaranteed you're narrow.
Yeah.
And it's just like,
Yeah, that's all right. That's amazing as well.
Yeah. It has to do with the location that you measure.
yeah.
What's probably going on with you, Pat, and this is probably where we had a little bit of a discrepancy, is I'm simply talking about this angle right here. But you might have a huge rib cage, and as this continues to go out and out and out, and maybe you're doing something where you tilt the pelvis so far anteriorly that these guys flare out differently, that it looks like you're wide as all hell. And maybe that's the case with you as well. But you also have a crap ton of muscle mass that's also making the wideness apparent.
Is that really what it is? Because just visually seeing someone that's just so wide,
Yeah.
it's not necessarily
No, and you can't. You're seeing lats.
Feels like a wing.
And we can't trust visual inspection because I'm only talking about this.
No, I know. I'm just saying, like, even what James is doing with his thumb, saying, hey, like, as this gets wider, but that it just looks wider. Like, that looks like a more obtuse angle versus a less obtuse angle.
Yeah. All right, guys. Go ahead, Benjamin. So we're looking at infrasternal angle. So remember, here's what we're measuring. It's this right here. And maybe it's helpful if we practice this among one another. So, that's hard. So what I want to do is I'm going from the hard portion to when it gets rubbery, which is right there. Like, you feel how I can just kind of spring that back and forth, but as soon as I move up, like, there ain't no spring in that. All right? So I'm taking my thumb. When I measure this clinically, I use my thumbs to see it visually, but then I also put a goni on it as well, because I can't tell the difference between 45 and 55. Like, I'm not that good. I'm gonna then outline this right here. So I just did that to Pat on the left side, okay? My other hand, same thing, where I can even do it one side. You see how that angle is probably less than 45 degrees, right? Are we clear on that? Yeah. But if I measure Pat here, holy shit, he looks wide as all hell. But that's not an infrasternal angle. That's just the lower portion of the rib cage. There. On the other side, bro, it's narrow. Narrow as all hell.
Narrow little
I'm gonna test Ryan as well.
Yeah, and I'll look at you as well. But what's probably happening, Pat, is like, look how, you and I are similar in that regard, and that's about as similar as we get. But look at all the mass and tissue you have here. Like, you have crazy external obliques that are probably tensed up to allow you to do the great things that you do to move weight, because that's how you're going to best pressurize this, given the constraints that your spine has given you.
Yeah.
You know, and also too, man, you lift. How many lifters have like that flat back kind of thing?
Yeah. It's a chimp spine.
It's a chimp spine, right? So this is a progressive adaptation that you've done in order to meet the demands of your life.
So the angle is here, thumb to thumb?
Yeah, or like you can either do
Or you
this
can
one.
just go like thumb to finger, like that's
I
one
use the
side.
tip of my thumb as the apex,
Okay,
and then the body of my thumb as the angle.
that's okay.
And I'm looking, like for a guy like Pat, because he's fairly narrow, like I would probably do one side at a time, and then I would get a goni on there as well, goniometer to measure the total angle.
When you're working with someone, just tell them breathe comfortably.
Yep. Yeah, I'm saying just chill. You know, I'm talking, making jokes, stuff like that, and I'm just going through all my stuff that I would normally look at. Yeah, I mean, and Ryan, let's use you as an example as well, because
For that question.
Would you say any avid weightlifter is going to be narrow?
most likely.
So he's
most
gonna be
likely.
wide then.
I would say Tio's probably narrow. Like I said, Mike, I didn't think you'll be narrow, but you might be the only other one who I would say would potentially.
I also have thoracotomy, so my head's been cut all the way down, so it's gonna alter stuff too.
Yeah. So hard. Very prominent xiphoid, like that's you right there.
I get that a lot.
But you see, guys, like that's
Narrow.
narrow.
This?
Yeah, it's
Or this?
asymmetrical.
Yeah, that.
The total angle is narrow, but even if I look at it one side at a time, less than 45 degrees, less than 45 degrees. Go ahead and relax your head if you can. Less than 45 degrees. You know. But again, like, well, if I look at him here,
Yeah.
right, the external obliques
Mine doesn't care.
are doing this, so they're making him appear longer this way. So if I go this and push this more forward, well, guess what? Of course, they're going to be way more prominent, and that's going to look like my dude is wide. That makes sense?
Yeah. That's super helpful.
Can I see you, Mike, too?
Yeah.
I don't know. I think he's going to be narrow as well. Like I said, I mean, we're all pretty just bros.
Maybe John did. Maybe John did.
Nah. I mean, nah, you're narrow as well.
Chad.
Lexer? Actually, can I?
Yeah.
Might be, maybe. But like I said, I kind of knew going into this.
Chad might be.
Lay on that bet. It's never gonna go do anything.
No, I mean, see, it's the same thing. And this is mostly what I see, guys.
What about Jenny?
Yeah,
Jenny, no, dude, Jenny?
Thank you.
Like, they did on the table the other day, and Jenny is just like butter.
Yeah. But that would be how I measure this. Yeah, I'll take it.
I'd have to use your pinky fingers for
He's
this one.
probably pretty good, man. Seth moves really well.
Yeah.
No.
No. So what may happen though is my man Seth. Yeah, I mean he's been able to compensate by doing things more appendicularly to allow him to move well.
That guy is 65. Everyone in this room.
We can't put this on the
I would
internet.
say he's
You thought you were gonna be able, you thought you were gonna put that on the
This is
internet?
Elite Magnet.
But in his
Why do you
case,
think this is a recording?
but in his case, you
this
can have
live
to
stream?
test. I wish to be able to say it because you can
Yeah.
have the case where I have someone who's this, and they can do things compensatorily elsewhere where that's no problem. Are we doing okay with how to measure that and the possible scenarios you see?
Yeah.
There's one other possible scenario, and that would be the asymmetrical one. If you understand both of those, you'll get the asymmetrical. Typically, because of the normal constraints within our organs, this diaphragm on the right, because of the liver, can't descend as far as the one on the left because there's nothing there. So I'm going to be more predisposed on the left side to be narrow and on the right side to be wide. Yes.
Someone who like developed like Harrison grooves, would that be more like presentable of a wide infrasternal angle?
You kind of have it. And I would say it's most likely a narrow in the most cases. Yeah. But again, I would say, just still check it.
Yeah.
So the left is more likely to be narrow?
Yes. Further descension. As I descend too far, I get an inversion of mechanics.
Right flare.
Well, it would be the angle. The infrasternal angle is different from the flare. The flare is how prominent the lower ribs are.
Yeah, I got you.
And you can have a flare in either case. In the narrow, it would be more of a pointed flare. In the wide, it would be more of a broad flare.
In terms of the actual mechanics of the inversion itself, what I'm kind of visualizing is a plastic bottle, just to kind of make a model in my head, a plastic bottle with like a balloon full of gas at the top, and we squeeze, and as we let it go, it comes back in, diaphragm wraps around the top of the bottle. Does that make sense?
I can't picture it. I mean, say it again.
You have like a plastic bottle that I've squeezed into a balloon.
Okay,
full
yes.
of gas, and as I release my hand in the bottle, the gas goes back into the bottle and wraps the balloon around the top of the bottle.
I can't
I think you're right. Yes, I think you're right.
Kind of what I'm trying to model in my head, what it actually looks like.
Yeah. We'll have to see this.
Shows with your mouth.
Yeah.
In someone with a left rib,
I mean, present yourself.
It's
is
already
it
gone.
clear that we're seeing the lower ribs being
Yes.
wider?
Yes.
Do you almost always see
Flare is
It's most hurting this.
that. Is this coming out? It's
When
not
the-
up here.
when the infrasternal angle is more narrow? Is the lower ribs typically wider? Do those usually go hand in hand, or is that only with compensation from the external obliques?
I would tentatively tell you yes.
Yeah.
Typically, you get kind of like that broad, like it's just the rib cage is longer
Right.
in those people, so it can appear more widest because the angle is much larger. Whereas in the wide, if I'm bucket handled way up, I'm not as long down here, so everything is kind of more compressed
Gotcha.
in terms of the rib cage.
So for your test retest, is this kind of your barometer now for your interventions? Did it work? Did it not work? Or there's other things you're using as well?
Yeah, it's my primary measure. It's my first line decision maker. But I'm also looking at shoulder motion. I'm looking at hip motion. And that's really it. And then whatever test is meaningful for the client. So if they come in to see me and it hurts to touch their toes, I'm always going to go back to that first and foremost. Because if I don't change that, none of this matters. They don't care about their infrasternal angle. They care about moving better and moving with less pain.
Are you going to go over, like, if someone's narrow, this might be a good strategy to use. If someone's wide, this might be a good strategy to use.
If we're doing okay time-wise, yes. Ben, we good?
You have 1 minute.
2 minutes.
2 minutes?
You can also refer them to you and Lucy's websites. as
Yeah,
well.
I mean, you can check out my website if you want.
Can you just keep going?
I would love to just see kind of what you would do.
Well, it's up to you guys. Like,
Yeah.
we can obviously stay here all day long. It's just if
Okay.
you want free time in the afternoon, I don't give a fuck.
Cool.
Keep going.
That's it.
All right. So if we can think about this, like simple heuristic to do this effectively. I need to get Seth to be more wide. And I
And
need
tall.
and tall. But you've already capped out on good looking. And I need to get people who are wide more narrow. So if we can think about, from a muscular standpoint, what guys can do that, and then from a respiratory standpoint, how can I maximize ribcage mechanics based on what we know from an inhalation-exhalation cycle, then we're in business. So for someone who's narrow like Seth, things I need to do. This is smaller, side to side. So that means this is longer, side to side. Don't use visual. You have to think mechanically. So what I have to do is I need things to push him down anterior and posteriorly. From a transverse plane standpoint, I need to bend the ribs, because if I bend the ribs, I can increase the bucket handle action, then we're good. So from here up, that's kind of a giveaway, what muscle can bring the sternal portion of the rib cage back, can shrink it anterior and posteriorly? It'd be on the front, it's pecs. If I contract, these guys run here, the pecs run here. If I contract these guys simultaneously, they're gonna pull this back. It does this, right?
More bench.
More bench.
That's like the same cue that Ryan used with you yesterday on the tech fly. Just drive your
Mhm.
strength back. Close
Yeah.
up.
Yes.
He's onto it.
What about here? Why? And
What did you say?
Because what you said based on if the right infrasternal angle is wide, then they're going to be more compressed. And then on the left, if it's narrow, they're going to be more narrow. They're going to be more long.
well, it has to do with the transverse plane action of the abdominal muscles on the lower portion of the rib cage. So if you can think about external obliques, externally rotate, they do this. Due to their attachment site, they're going to make this longer, and in order for this to increase, the ribs have to do that. They have to ER, right? So if these guys are on, Internal does the exact opposite. In transversus abdominis, if you look at their attachment sites, they're going to internally rotate the rib cage. So that's how here we're going to decrease, or actually increase the lateral dimensions of the lower rib cage. Okay? Now, in the narrow case, what's going on here with the hemipelvi, or the infrapubic angle? Is it narrow or is it wide?
Narrow.
In a narrow. It's narrow. Because in compensatory situations, the angles should match.
Yeah.
All right?
Do you check that?
Yes. Yes. Under normal circumstances, which we never see, they should be opposite. Because we're trying to expand that ball, the thoraco-abdominal pelvic cavity, in all directions to maximize gas exchange. All right? Now, what muscles could pull this apart? Could pull that infrapubic angle apart? Boom, 100%. All right? So he needs pecs, he needs internal obliques and transversus abdominis, and he needs adductors. Now, I wonder if there's an activity that we could drum up that could do that.
Diamond bear.
Diamond bear is a perfect example. But I don't care what you do. Like, Dave and Lucy, how many times have you guys had conversations with one another where I come up and you're like, is this okay? What would I tell you in that situation?
Do you get the outcome you want?
Yeah, I don't give a shit what you do. Get the outcomes that you want. And you don't even have to use this as a test. This is just what I use because I find it to be very impactful. But as long as you're getting the outcome you want, I don't really care what exercise you drum up. Just do things that get outcomes your clients want.
Flies with your pecs. Shit, dude.
You can get changes
Fucking
with...
put a ball between his legs.
Good girl with
Yeah.
deck.
Yeah.
Yeah.
Let's build it.
You
Build it.
But like, you say that jokingly, but I've done stuff like that that works. Like, it doesn't have to be this low intensity stuff that we're about to do with Seth. All right? But let's try that. Now, so we know we need pecs, we know we need IOs and TAs, and we know we need this. What type of exhalation strategy would be beneficial for this guy, do you think? Why?
This R gets external obliques.
100%. That's one way they use to get a maximal voluntary contraction of the abdominals. And if I go hard and my diaphragm's already kind of flat, well, the EOs are going to contract things further and won't allow that full ascension. So I need a soft exhale to make that happen. That's the difference. Now, so that's the exhale portion. So we get the full exhale. He gets all the air out by sneak attacking around the EOs to allow this to ascend. I use a pause to allow the diaphragm time to ascend one, but also to change pH levels. What's the inhalation going to be like? Slow, easy. Slow, easy, soft through the nose. So he maintains that position. He doesn't use any accessory musculature to help him get air in and he loses position. Because then we got problems. Okay?
Is the inhale ever not as soft?
I would say no. Because when you're inhaling, you don't want the inhale, and because in both of these cases, and really all three of the compensatory cases, you're dealing with relative degrees of hyperinflation, I don't need to drive more air in.
If you were wide, would you go hard exhale?
Yes. So if I'm wide, the strategies are pretty much the exact opposite from a respiratory standpoint. This, and I can't demonstrate on you, but this is way open. I need the external obliques to close that bad boy because I need to make that person more narrow. So I use a hard, forceful exhale to close the infrasternal angle, allow zone of apposition development, life's good. And then really, in terms of mechanics position-wise, you're just doing things, we always say like arms overhead. All that's doing is that's pulling the abs on a greater stretch, so you get a muscle spindle activity to create further enhanced contraction.
Is there any use for a balloon with the people that have narrow infrasternal angle?
I think you can still get outcomes.
Yeah.
Because, we've done...
Dobbs has like the...
Yeah, but again, Dobbs is guaranteed narrow.
Okay.
It's not that you're not going to get results. It's how accurate can I be with my decision making to elicit a change. Because I've done, with people who are narrow, I've gotten results using a balloon or a straw or anything like that, because you're still getting air out, right? We're still putting people in good positions to elicit the changes that we're looking at appendicularly. But if I want to be more precise about what this person needs, I'm going to look at that. Can I talk about you?
Absolutely.
So I eval Jack while we were here, and when I tested him, he was clean everywhere except his left hip. That was it. Like, came in, every test was normal. It wasn't like a laxity type thing, because like on some people, when you do horizontal abduction as an example, you see the anterior humerus just pop out. But like with a guy like him, old me would have said, well, sure, there's nothing I can do for him. He's probably, he probably needs some type of orthotic that I can't provide him with. But then if I look at this, it's like he's just been able to compensate so good at his appendages, but this was never addressed, right? So I still need to look at something here in order to list the changes I want. And I think that's probably why we still got good outcomes if you're doing a balloon on someone who's in narrows, because you probably put them in a good position to address the appendages. But did you truly clear out the axial skeleton as the rate limiting step for someone? And that, I don't know. And that's probably why I think a lot of people don't get changes that stick. It's because we didn't take this into account. Because once I started doing this more, I see changes sticking more. And that's because I addressed the primary thing, which is respiration, diaphragm position, axial skeleton.
So just in terms of how that would fit, for example, into a PRI framework, after you address the axial skeleton and ribcage position, are you just continuing in a relatively similar manner to what would be traditionally prescribed?
Yeah, 100%.
It's the same thing.
It really is the same thing. Yeah, and I mean, I use similar exercises, or I make up other exercises, and like there's probably some other things I'm doing maybe slightly differently, especially as we go out this way, because sometimes there's compensatory things that can happen at the humerus, at the elbow, at the wrist, at the knee, at the foot, that might be slightly different. But as long as you understand what normal mechanics are and what it should present as, and if that is or not there, then you're making the right decisions. I mean, my general rule of thumb is once you've addressed the axial skeleton, find what position they can't get into and put them in that position, let them struggle. Does that make sense?
Yep, absolutely.
In someone who has an asymmetrical rib cage, so it's a narrow intersternal angle on the left, but not on the right, would you go after the left pec only?
Mm-hmm. Yeah, I would.
Does that change depending on what you see at the humerus, or no?
Yes, after I've done this.
Okay.
That's why I gave you left only, because you were more narrow on the left side. So I gave him a activity that focused on left pec only to try to open that up.
Do you know what the thought process was that told us to try to inhibit left pecs initially, and how that changed down the line?
Yeah. So, well, I can't speak because I know.
Or I guess that research that developed, let's inhibit a left pec.
Yeah. So I can't speak on PRI's behalf, but I will give you my interpretation of things.
Sure.
When you went after left pec inhibition for them, that was typically after you cleared all other shoulder measures. So I have someone who has normal shoulder rotation, normal shoulder flexion, but and normal stuff on the right side, but left horizontal abduction is limited.
Yeah.
And that would be due to the pec.
Gotcha.
But if we also think about it from a respiratory standpoint, on the left side, if I'm narrow here, where am I good at filling at? Anteriorly or posteriorly? On a narrow, it's left, it's anterior, because the backside flattens. So I'm good at filling this up here. Well, if I'm good at filling up here, what does that, what does that do to the scapula? Is it going to be more protracted, or is it going to be more retracted? It's going to be more retracted. So then what does that do with the attachment of the pec at the sternum versus the humerus? It's long. It's eccentrically oriented. Why wouldn't I do a concentric activity then to reverse that? And once I figured that out, I was like, oh my gosh, like this makes total sense. So I don't think it's incongruent with what they're saying, even though that's not how they address it.
Right.
I did see James teach it that way at AI this year, where he was just talking about that enormous left chest wall in terms of being stretching the pec on both sides.
Yeah.
So
Yeah, and when I went through the PRC this year, they basically said left pec stretching is the last thing you would ever do. And it's only if you've cleared literally everything besides left horizontal abduction, and it seems very clearly orthopedic.
Yeah.
Meaning like they actually have a tight muscle. It has nothing to do with position. So
Yeah.
I think it's more, it aligns more than it diverges.
For sure. But then what if you think about someone who maybe has a horizontal limitation on the right side isn't wide? Because I'm sure you guys have seen someone who has an IR limitation on the shoulder, but also a horizontal abduction limitation. What about that person?
If they're wide on the right?
If they're wide on the right and they have IR and horizontal abduction limited.
that could be a tight pec at that point.
100%. I'm pulling everything this way.
Right.
Pec minor gets leveraged to pull the scap in that direction. I go back, boom, I can't do this, but oh wait, crap, everything's on here. Problems. And the pec, both major and minor, will help with the pump handle activity of the ribcage and apical expansion. So like, why wouldn't that be the case in which we would stretch apart? But it's just not part of
it would.
what that pattern that we're talking about.
What direction does the sternum go in the transverse plane when you see the narrow angle on the left?
It would go towards the right.
It orients right.
And here's why. What do I have on this left chest wall? Am I good at getting air on the left chest wall anteriorly, or am I bad?
Good.
I'm good. So then that would be an increase in pump handle activity of the sternum. Would you agree? Well, if I only do that on one side, there it is.
Yeah.
That's your orientation. Now, this is different than trunk rotation. This
Right.
goes right.
It's orientation.
It's oriented this way, but the trunk rotates to the left.
Gotcha.
The twisted feeling? Would that cause a twisted feeling?
Potential contributor. Because this, if we look at the research, there is a normal, we all have a normal scoliosis that is right rotated and right side bent. So there's obviously a lot of people who have that, but not everyone feels what you feel, Jack. So and that's where like stuff that Eric's talking about and really everyone else, that's why we have to have this comprehensive model, because I don't know. Like my job for you, Jack, is to rule this portion out as a contributing factor. Once I've done that, once I've gone through my model and exhausted all possible options for you, then it's like, I'm not your fix. Maybe Ben's your fix. Maybe Pat's your fix. That's the difference maker. And it's just my job to say, hey man, I did all that I could for you, and then making sure you get to the right person. You know, my goal is to eventually still be that person for you, but maybe intervene at a different level.
You know, I think in seeing a lot of people benching over the years and like thinking about injuries, it's like always left pec. You almost never hear anybody with it. And that eccentric orientation, I think, makes so much sense in that regard. But you know, my question is really like, you know, I would think that I would be creating a more concentric situation for a left pec with a bench press. So why am I seeing a lot of these injuries? Like, you know, I don't know, maybe you're hearing where I'm going.
Yeah.
Filling my blanks for me. It's a
Well-
bad question. I don't even know exactly what I'm specifically trying to ask other than why left pec injuries on bench.
Well, one, everything Eric talked about, first off. Second off, it depends on how the bench is coached. If I'm coaching it with a traditional powerlifting measure, where I'm trying to create that shelf, I don't get the full glide. So I'm probably not getting, I'm increasing the eccentric position that the pecs start at. So I can minimize the distance that I have to travel with the bar. So if I'm teaching it that way, then I can still see you're still trying to load a pec from an eccentrically oriented position that's reinforced by the position of the bench.
And maybe it's happening on the lower phase. I don't have enough information.
I would say from a variability standpoint, that's what I'm thinking. And especially if you haven't given that person all the degrees of freedom needed to complete the task. Because like what I just showed you, that's how I coach the bench, because it's efficiency. And I feel like you get a good load on the pecs, among other things. I know that's a little bit of a different point that we have. But I'm only doing that if I have someone as much degrees of freedom as they need to complete the task without a problem. But I would also venture to guess too that under severe stress like a heavy bench, they're going to go with what they know, and that's what they know. It's like, even though that's a bilateral movement, it's still a asymmetrically loaded unilateral movement because we're always to a degree asymmetrical. Gerard.
Wide, you go strong exhale, narrow, you go soft. How do you choose what type of exhale you use when you have somebody who's asymmetrical?
In that case, go with the worst situation. So I still treat them as a narrow because this needs more distance to ascend than this side on the narrow, or in the asymmetrical case. So I still go with a soft exhale, but what I'm changing is the position of the appendages.
Do you have a prerequisite for people that can't hold their breath during the pauses or exhale for 5 to 8 seconds at a time?
Break it down one thing at a time. Typically when I'm coaching this, and I'll just demo it as I would with the client, is I go over the breathing aspect first before I even throw the position in, because if I try to do it all at once, it's too overwhelming. So I make sure that you have the exhale down pat before we even move to the pause. So it's like I'll go exhale, coach that, and we're just sitting breathing. Then it's inhale, silent, we're just doing that, and then it's exhale again, and then pause. And so I just break it down sequentially like that. And if we don't make it to the exercise, like, that's cool. It's like you still need this prerequisite before I can take you to the next step. You know, you guys have all seen changes, I'm sure, just by coaching breathing in some way, shape, or form. Whether it's not how I teach it, or whether it's meditation, or whether it's any frequency-based breathing.
I know we talked a lot about narrows in terms of wide external angle. What muscle groups are we going after?
For the wide?
Yeah.
External obliques is the biggest priority, I would say. Also, it depends on what presentation I look like here. But in theory, if it's like a normal compensatory wide, glutes,
ER fibers?
piriformis,
So ER fibers of the glutes and the extension fibers?
abduction. So glute med. But I would also go with external rotation as well. So, yep. And then, but if I have a case where I have someone who's exaggerated the curve so much that the pelvis has tilted forward, and I have adduction limitations at the hip, scratch that. What I would go for instead is something to reduce this lordotic curve. That's where the hamstrings can come into play. But it's not because of the posterior rotation aspect of the pelvis that their action is. What it has to do is what they do to the sacrum. Because what they can do via their attachment of the sacrotuberous ligament is create sacrocolumnar nutation. Yes. So I get a little bit of a hamstring contraction, not enough I'm getting a crazy posterior tilt, so I can reset the spinal position. Because if I can get that change at the sacrum, I'm going to get a corresponding change of the rest of the spine. Life's good. Especially when combined with the exhalation strategies I'm going to show you.
That was in regards to a mismatched wide infrasternal angle, wide infrapubital angle? That question?
Yes, but super compensator.
Okay.
To where your Ober's testing is positive with that person.